Yes, it was great. You did a great job.
Hi, Robert. How are you?
It's not Monday, so I feel like I'm already just a little bit. Oh, how are you, sir? Good to see you. So, somebody just told me that the weather this weekend is going to be.
It all mixes.
Yeah, like torrential. I mean, like. Yeah, like no one. So, yeah, it's. I've just been trying to get out and actually do some yard work, but I can't because it's.
Okay, I'd like to begin our second panel and begin by introducing, you could take seats, please. This is the order in which panelists will speak. We're going to start with Jim Matthews, who's Executive Director of MedPAC, and he will describe the Commission's analysis and its recommendations on MIPS and anything else he'd like to say. Then hear from Matt Fiedler, Fellow in Economic Studies at the Brookings Institution, and who worked with Tim Groninger to lead the analysis of the USC-Brookings Schaeffer Initiative for health policy work that Tim put up in a slide. Then we'll hear from Sarah Levin, who's a member of the Democratic staff of the House Ways and Means Committee. And finally from Robert Horn, now with Levitt Partners, but who served on the Republican staff of the House Energy and Commerce Committee when MACRA was developed. Jim.
First, I'd like to thank Paul and the staff of Brookings for putting on this event and for inviting me. I'm privileged to be here and thankful for the opportunity. I also, unlike the previous panel, I do not have slides, so you're just going to have to watch me talk for the next 5 to 7 minutes, so I apologize for that.
That's the case with all our panelists. I discouraged slides.
But it's a very nice background slide, so that should take some of the strain off. What I would like to begin with is I had originally prepared 2 presentations in response to the question of this forum, can MIPS be salvaged? And the first one went something like this: no, I'm happy to take any questions. But in the interest of developing that thought a little bit further, I do want to represent MedPAC's current position with respect to MIPS and spend a few minutes talking about the evolution of our position. So we recommended eliminating MIPS in our March 2018 report to the Congress. Some of you may have heard about this. But I'm going to rewind for a little bit and talk about the origin of that recommendation. And it begins with a recommendation we made 7 years earlier to the Congress that the SGR system be eliminated. This was something the Commission had felt very strongly about over the years in terms of its impacts on physicians' willingness to treat Medicare beneficiaries and fully engage in the Medicare program. And so in 2011, we made a recommendation that included, some fairly draconian payment updates for the, decade ahead. And it was an indication of how strongly the Commission felt that the SGR needed to be eliminated. Congress did indeed eliminate the SGR in the MACRA legislation, and it was a tremendous accomplishment. We, again, were completely on board with the notion that SGR was serving no useful purpose. We also were very supportive of the new path laid out in MACRA with respect to alternative payment models as a mechanism to incentivize and help physicians engage in delivery system reform. So very supportive of that effort, and we're continuing to develop ways to improve the AAPM process. Then we get to MIPS. And MIPS, we were fully on board with the notion that there should be a value program available to non-organized, non-AAPM physicians. Many of our commissioners over the last several years had expressed this sentiment in very clear terms, and so we are very much in agreement with the goal. But over the last 2 years, we've come to the conclusion that MIPS is simply not going to achieve those goals. And I'll spend the next couple of minutes talking about why we believe that. When MIPS was first proposed on a regulatory basis in 2016, the Commission's position was that we would, help CMS try to improve MIPS. But even at that point, we were raising some concerns about how it had been articulated. And we suggested focusing more on outcomes measures, reducing burden by using claims measures, and a number of other issues. But we still started to raise some doubts about, the viability of MIPS as a broad quality improvement program for non-AAPM physicians. And over the following 2 years, as the agency continued to roll out regulations, refining the program, our concerns became even more pronounced, and we ended up concluding that MIPS is simply fundamentally not fixable as a broad value program for physicians. And there are a few reasons for this. And I want to emphasize here a broad value incentive program for physicians. First of all, there are numerous statutory and regulatory exclusions to the MIPS program. By rough estimate, we think currently 600,000 physicians are excluded as a result of regulatory decisions that the agency has made, and another 300,000 or so are exempt by statute. So almost 1 million are exempt compared to a little less than 600,000 who are subject to participating in MIPS. So in terms of a broad program to incentivize value, you've left 2/3 of your non-AAPM physicians kind of off the table right out of the gates. A second concern that we had is with respect to the small n problem and statistical reliability. That given the fact that you're talking about measuring the performance of individual physicians, even individual physicians who are subject to MIPS and who are selecting their own measures may not have sufficient volume to have their performance assessed in a statistically reliable way. So you're starting to move Medicare dollars around on the basis of random variation, and that's a point I'm going to get to in detail in a minute. We also had concerns about the low performance thresholds that I think the minimum performance threshold now is 15%, and the exceptional performance threshold is currently 70%. And I don't know about anyone in the room, but if one of my kids came home with a 70%, average on their report cards, I would not call that exceptional performance. So we're talking about a very, very low bar for purposes of, again, moving substantial quantities of Medicare dollars around. We are also concerned about the fact that, as currently constructed, physicians will select their own set of measures, and this creates a couple of problems. One, you cannot equitably compare the performance of one physician to another. And again, this is a fundamentally unfair prospect, again, with respect to Medicare identifying one physician as being better than another one, and therefore you are going to get more dollars than you over here. Not you personally, but. So there's also the problem of physicians selecting their own measures, and they will likely, or at least this is what I would do, select measures where I would have the best chance of performing extremely well. This is just human nature. So what's going to happen is you're going to get measurement compression, where you're going to see a lot of physicians performing at, the 98th, 99th percentile on their different measures. And as a result, performance, good or bad, is going to be assessed on extremely fine gradations within, a very high top of the spectrum in terms of their scores. And this is going to, it might not make much of a difference now when the payment adjustments are, in the 1-2% plus or minus range. But when you start getting into the -9 to +30, this is going to make a real difference. And as MedPAC has talked to different physicians out in the community, one very compelling anecdote we heard was, how do I explain to my family that I've just taken a $20,000 pay cut due to random variation? Big problem here. And then there's also the question of burden. So I think virtually everyone on our previous panel mentioned burden, no benefit relative to the cost, no return on investment. And CMS estimated close to $1 billion in compliance costs in the first year of MIPS, and we are projecting $500,000 annually in compliance costs on an ongoing basis as long as the program exists. And again, this is for a program that is not going to really measure performance at the individual clinician level. And, a lot of the advocacy organizations will argue we've spent a lot of dollars, we've made a lot of investments into this, we can't stop it now. But, how long do you want to keep throwing money into a program that, is not going to fundamentally achieve its goals? And at the same time that some of the advocacy organizations are making this argument, others are, having campaigns to their members that say, one measure, one patient, no penalty, which in my mind does not sound like broad-based quality improvement and incentivized, value on a broad basis. So on the basis of these concerns, MedPAC recommended in March of 2018 that MIPS be abolished and instead replaced by something that we call the Voluntary Value Program. I'm cognizant of the fact that I'm running long on time, so I won't go into it in tremendous detail, but under this construct, groups of physicians can volunteer to be measured on a small set of population-based outcomes measures, similar to the measures that we have in mind for AAPMs. That's an important point. And under this construct, it solves at least 4 major problems with respect to MIPS. One, it solves your small n problem. You can only be measured if you've got a sufficient number of participants in your group. 2, it solves the burden problem. There is 0 burden to this approach. Most of these measures are claims-based, which would be calculated by CMS, or there are patient satisfaction measures through exogenous surveys that could be used. It solves the equity problem. Each group of physicians is going to be measured on the same set of measures. And again, there's numerous questions and concerns about what MedPAC has proposed, and I could take that on question. But the last thing second to the last thing it does is it solves the value program. The measures that we have in mind are not things like, are you adequately assessing your patient's blood pressure on a regular basis, but they identify things that are important to the Medicare program and its beneficiaries. And then lastly, this approach does provide an on-ramp or some set of training wheels for clinicians to come together as groups on an informal basis under our construct. But since they're going to be measured on the same kinds of things that in our vision would apply to AAPMs, this does allow them to kind of try it out before deciding to go that next step and take on risk for the cost and quality of care for their aligned population. So with that, I will stop talking and turn it over to our next panelist.
Given that, as Tim alluded to, he and I have, along with Paul Kavita and a couple other folks here at Brookings, co-authored some work on this topic. Probably won't surprise folks that I am also on team Let's Abandon MIPS. I'll try not to repeat what Tim said, but I think there are 3 basic points that drive me to that conclusion. I think the first is that the empirical evidence more broadly on sort of value-based purchasing and pay-for-performance type programs that measure clinicians on a range of different cost and quality measures and then adjust fee-for-service rates upward or downward on that basis is just very weak. I particularly like there was some recent work by Eric Roberts and colleagues on the value modifier, which was a predecessor program to MIPS, that looked to see whether there were changes in physician performance at practice size thresholds where practices became eligible for bonuses or became eligible for bonuses and penalties under the value modifier. They found that there was no evidence of changes in performance at these practice size thresholds, which strongly suggests that these types of incentives were not, in fact, changing behavior. And that's not a unique finding to the value modifier. Lots of the research on these types of programs, including the hospital value-based purchasing program and others, finds these programs to be fairly ineffective tools for changing behavior. So that leads me to believe that MIPS is likely to go down a similar road. Now, perhaps you thought that these reflect fixable design flaws in these types of programs. I think for a variety of reasons that other people have touched on, I'm not optimistic on that front. I think the small numbers program that both Tim and Jim alluded to is just sort of fundamental here. You're going to have, when you're trying to do clinician or practice level quality measurement, you're just going to have very noisy measures. And that's going to mean the sort of amount of incentive kick you're getting for the amount of risk you're exposing providers to. It's just not a very attractive trade-off. I also think when you're in a world of clinician or practice level payment adjustments, it's very difficult to create a coherent set of financial incentives that way. I think in the MIPS cost domain, we have a great example of that. We have a need to measure lots of different types of clinicians, and so the approach CMS has taken is do a bunch of different cost measures, throw them together, average them together, and that's your score. But because each dollar is going to, depending on who meets the sample size criteria and which measure you're using, each dollar is going to be counted. Each dollar spending is going to be counted multiple times or not at all. The overall set of incentives we're creating to sort of think about the overall cost of care is pretty haphazard and scattershot. Some of that sort of problem may actually explain part of why these programs have been ineffective, in that it's the scattershot set of incentives makes it hard for providers to figure out how to respond to them. It may also mean that even if providers did figure out how to respond to them, we wouldn't be thrilled with the types of responses we saw. And then I think so if we have a structure that we think is unlikely to work based on prior experience that we probably can't fix, I think other people have alluded to the fact that it's not costless to operate this program. So, those administrative costs might well be worth paying if we thought we were causing real changes in quality or reductions in the cost of care in a world where we're operating a program that seems to be pretty inert. They're very difficult to justify paying. So for those reasons, my view is that the evidence justifies abandoning MIPS. But if we were in a world where Congress were taking action to repeal MIPS, which may not be the near-term world we're living in, but maybe will be the world someday, I think this would be a good opportunity to implement other changes that might reduce the cost or improve the quality of the care. I think that probably will take a lot of different forms. I think as we move forward, there's been a little bit of a focus on silver bullets, and in fact, we're probably going to be looking at sort of multifactorial approaches to deal with many of these problems. But I want to focus on steps policymakers could take to make alternative payment models more effective in Medicare, given that APMs were the other main reform pathway that was envisioned in MACRA. So in contrast to the value-based purchasing programs, my read of the evidence to date on APMs, it leads me to be cautiously optimistic that these can be effective tools. On the bundled payment side, early evaluations of CMMI's voluntary bundled payments program, main voluntary bundled payments program, seems to suggest that these models can generate modest savings without impairing quality, though there does seem to be some variation from episode type to episode type, with surgical episodes, I think, at this point having stronger evidence of effectiveness. On the ACO side, I think the best work is probably by Michael McWilliams and colleagues looking at performance in the Medicare Shared Savings Program that, again, seems to find modest, but what I would call meaningful reductions in spending under ACOs alongside modest quality improvements. For a variety of reasons, my suspicion is that as providers gain experience with these models, the savings will likely grow, and I think there's also some reason to believe that as these types of models scaled, there might be systemic changes in sort of how medical practice and even medical technology involved. That would mean that their long-run impact could be larger than what we're able to measure in the short term. So that's why I think this is a valuable road to go down. What do I think the sort of useful role for policy is beyond what we're doing now to make that possible? This is where I get a little more radical. I think one of the major barriers over the medium term to realizing the full potential of these models is that they are right now, for the most part, purely voluntary. That creates a number of challenges, but I think the biggest one is how to set provider spending targets. So the spending benchmarks in ACO models or the target prices in bundled payment models. Initially these models have solved this problem by setting the spending targets based on providers' own historical cost experience. And that's a great place to start, but it's not a viable strategy. If you're a provider that's recognizing that, wait, if I save $1 today, then when they reset my benchmark in a couple of years, they're going to look back that I successfully reduced costs before, and so my future spending target's going to drop by $1. That's not a particularly sustainable financial model. It's not one that creates strong incentives. This approach also tends to lock in historical cost differences, which is going to reduce the incentives for efficient providers to expand and serve more patients and weaken the incentives for inefficient providers to contract. The problem is that the natural alternatives to that approach in the context of voluntary models have some real challenges associated with them. I think the most natural place and the place that I know MedPAC and others in the context of ACOs have suggested going is to set spending benchmarks, for example, based on regional average spending. The problem with that is in a purely voluntary model, providers with above average spending are likely to drop out of the model. Providers with below average spending stay in the model and realize big windfalls. So I think that does mean that over the medium run, if we really want APMs to be our key strategy, we're going to have to make these models less voluntary. That can, I think, be through a combination of carrots and sticks, and I think depending on the model, the right approach is likely to differ. On the bundled payment side, I think the right approach is probably ultimately going to be where we have models that we think work, actually making them mandatory. On the ACO side, it's not at all clear what it would mean to make ACOs mandatory or how you do it. So I think they're building on the bonuses for advanced APM participation that were in MACRA is really the right path forward. So I think step one is just to make sure that the 5% bonus doesn't go away in a few years. But I think beyond that, we should be thinking about making the financial incentive to participate larger. So would envision doing that through a budget neutral combination of bonuses for participation and potentially ultimately penalties for non-participation. I think it's also a question whether those bonuses should be limited just to physicians as the APM bonuses under MACRA were, or whether we should be expanding those to additional types of providers in order to expand the sort of set of providers that has a stake in making sure that these types of models are operating in any particular community. So look forward to the conversation.
Hi, thank you very much for having me here. I need to start with a disclaimer. The views that I am about to speak are my own. They are not necessarily those of the ranking member of the Committee on Ways and Means, nor are they necessarily the views of the members of the committee. So on to that. I think that Paul and Jim touched on this, but it bears repeating, stepping back a little bit and remembering where we were a couple years ago with the near constant conversation of the sustainable growth rate. And, SGR was started, as was discussed, in 1997, and since the early 2000s, there were repeated and regular cuts that were going to hit physicians that Congress had to stave off. And this would bring the physician communities to Congress saying, please don't have these cuts, and beneficiary groups saying, please don't cut my physician payments. I want to make sure I can still see my physician and be able to still see my doctors. And the conversation in healthcare was largely, in the Medicare space, was largely talking about how to get rid of the SGR and what we can do next. And so over the course of that period of time, Congress spent about $170 billion on short-term patches. And in 2015, the physician community was facing a 21% rate cut. And so in comes MACRA. And in the time post-Affordable Care Act, this hyper-partisan healthcare discussions, here's this bipartisan, bicameral work that is looking to talk about value of care and drive. And the whole point of MACRA and MIPS and the advanced APMs was to talk about how to move to a system that rewards value of care instead of volume of care. And that's a change of conversation from, how do we stop these cuts to how do we move to value? And it's reflective in this community right now we're talking about how do we make sure that we're improving care for beneficiaries and doing it in a meaningful way for an easier way for the physician community. So Congress established MACRA, which created this two-pronged approach. One is the advanced alternative payment model for those who are willing and able to take on risk for their payments. And those, a large section of the physician community who was maybe not quite ready to take full on risk, but, may be interested in value. And we heard loud and clear from the providers that not every doctor is the same. And there's variation in the readiness to move to value. There's variation in size of practice. There's a one-man shop. There's several hundred-person shops. There's location that, what a physician practice in Iowa or Tennessee, it looks differently maybe than one in New York City or Houston. And so there's also the physicians would come and say, I am different from another physician. You are going to measure my quality. I'm a pathologist. I don't see patients. How are you going to change my payments? I'm a family practice physician, so I care about, maybe these flu shot measures are relevant to me, but maybe a surgical measurement isn't relevant to me. So how are you going to make sure that any value proposition can speak to me? And so there are a lot of challenges, and since the physician community is diverse and both in size, scope, geography, what types of services and they furnish, trying to make a program that encompasses us all, and you want to make sure that there's opportunities for everyone to succeed and to continuously push towards that value. And so MIPS is an important part of that package to lead towards an on-ramp for those who may not necessarily be ready to move to value in 2015, or really the onset of MACRA, which started in 2017, then giving people the opportunity to do so. And it's a marathon strategy, really, and there are those who started who are more integrated practices who have been doing this, bearing risk for quite some time, started at mile 26 and only had 0.2 to go, and really understand and have the systems and capabilities in place to move towards that value in a more advanced way. And then there are those who are not even at mile one, and we need to set up a system so they're not keeling over before they get to mile 10 or 4. And so, there are those who talked about here in the earlier panels that there was MIPS can be used as an incentive to move towards that advanced APM, and that's really the goal, is to try to get everyone an on-ramp or movement towards those advanced APMs. And there's been a lot of concerns that are valid that have been talked about, and they're continuing to talk about here and in Congress. How do you measure performance in a meaningful way? How do you continue to push the outcomes-based measurements that are meaningful for physicians, that are meaningful for patients, and saying, how can I improve care? Or what type of care am I going to receive? And that is an ongoing process and something that needs to continue to be developed and moved on. But I will say that right now in Congress, that's the conversation, is how can we make these improvements? How can we move towards more value? How can we move towards outcome? And the conversation has not yet been how to dismantle MIPS. And I think that, just remembering that this was the MACRA, MIPS, and advanced APMs was a bipartisan solution that came after over a decade of short-term patches and from a long broken system. And this is year 2 of the program. MIPS really started in 2017, and we don't even have the results from the first year. Payment consequences haven't started. They don't start until 2019. And so we don't know how the program is working. We're very interested in how the program is working. We've had, in our committee, we've had several hearings on the implementation of MACRA. We had one earlier this year. Energy and Commerce Committee is having one next year. Congress has invested in making sure that it works and that it could be useful. We've made some technical changes earlier this year in the Bipartisan Budget Act, specifically dealing with providing more flexibility to physicians and more time to on-ramp, and to clarify some terms that were confusing and wouldn't allow the flexibility that we want physicians to need to use. But additionally, there were clarifications relating to the development of new advanced alternative payment models and making sure physicians have technical assistance to get to the point of developing those value-based models that both the physician community and beneficiaries want to see. Because we do want to, the whole idea of this is to lower costs and improve quality. And so, I think it's very important to hear all the perspectives on the different challenges, and I would say that the statute is pretty. There's been a lot of regulatory issues that have been discussed here, and I appreciate the discussion of that that Sherry talked about. There's a lot of flexibility in the law. But when we talk to the physician community and the beneficiary community, they're not coming in banging down the doors to repeal MIPS right now. As in the way that they were in SGR. They're coming down talking about how can we. I need an advanced alternative payment model. I don't have one. How can I get one? How can I? And that's a good conversation to have. How can we make the measures more relevant? How can we drive to allow more people to have this the ability to bear risk and to do more advanced alternative payment models, and to even do the alternative payment models that hopefully lead down the road to those advanced alternative payment models. And so this delivery system focus is important. And so we can bring everyone down the road, MIPS using that on-ramp to get to the point where we can have those bearing risk discussions, because again, that small rural practice or small urban practice is they're very different than the large integrated medical practices that have all the data analytics. And so moving everyone along is really the goal. So I'll stop there and turn to Robert.
Well, first and foremost, happy Friday, everybody. Look, I had talkers. I've completely iterated around those now, so let me just start this way, and I'll kind of go back and forth. First off, just let me note, I'm a Chicago optimist. It's a tough value proposition living in a town of absolutists, but that was a bad joke, by the way. I want to switch the question around a little bit that we were posed today, and I first want to talk about how MIPS and larger than that physician reporting can be improved and utilized as a tool of driving value, and then I want to answer whether MIPS can be saved or not. Two things to note, and really one to build off of Sarah. MACRA was a bipartisan law. It's still a bipartisan law. That's a really important part in this town and point in this town, because modifications, improvements, and areas to support the law are still very bipartisan. But as we think about basically MACRA and the role of physician reporting in a value proposition, MACRA was created to get away from the SGR budget tool that was utilized around the inflationary updates on the physician fee schedule. And it was created to allow for physicians to help drive value in the Medicare program, where before some might have thought of it largely as an ACO proposition. And so you could think about MACRA 1 as helping the physician community drive what the future of value looks like. And it's something that is still a very bright proposition. But number 2, it could be thought of as defining the ways to measure those value propositions. And that's largely what you could think of as MIPS and the APMs. APMs are the value proposition. MIPS, in some respects, are ways to measure that value proposition, knowing that reporting is going on in an APM as much as it is MIPS. In my humble opinion, MIPS is not just a measurement tool, though. It's also an opportunity for data aggregation, gathering, and the effective employment of data to support the identification and adoption of value propositions. My dad basically bought a new car, first-year model, when I was 6 years old, and he was so excited. He brought it home. He was bragging about it. 6 months later, that car was no longer in our front driveway because it had problems. It broke down, basically, and it got fixed. The funny thing about the car, it's a MIPS analogy, obviously, is that it was back in the driveway 3 weeks later, and it worked well. It really did. To Sarah's point, there are a lot of flexibilities in the MIPS program itself that can be utilized to improve physician reporting as both an opportunity to define what measurement looks like, but also as an opportunity to give CMS, CMMI, and others the data that it needs to identify and define what new value propositions look like. We may not necessarily be utilizing those tools as effectively as we can, but the flexibilities that Sarah spoke to can do that. One example, and Sherry brought it up, the combination of CPIAs and the reweighting of measurement and measurement categories within the law, if combined, can help define what new value propositions are from a measurement standpoint and also potentially an APM standpoint. Those aren't the only flexibilities. There's a lot of flexibilities. If you consider, too, the flexibilities that CMMI affords the administration, you can almost double those opportunities. Congress, as well, is not a passive participant in this. My guess is if somebody walked forward with a way to make the macro program more meaningful, that wouldn't be a conversation that they would shut down. And I'm not speaking for them. Sarah can speak better to that than I can. I no longer work there. But in thinking about basically MIPS in some respects too, let's think about the role of physician reporting beyond MIPS. Physician reporting can be a way to really identify what new value propositions are in the APM pathway. One of the areas of improvement that could be focused on are opportunities to tie the MIPS pathway closer together with the APM pathway. And it's an area of policy that I am working on with a broad stakeholder community, because I do believe that MIPS can be improved upon. I do not believe in the absolute statements that it should be gotten rid of. I think for anybody that points out a problem with the MIPS program, I would encourage them to think of a solution, not necessarily just a let's throw it away. And again, MIPS and the macro statute are not an SGR budget tool. They really are ways to harness and drive value. But one example of how physician reporting can be utilized better under the macro statute to drive the identification, adoption, and use of value propositions in the Medicare program is to allow physician reporting to report more on what we could call prototypes of what measures look like and what APMs might be. An APM largely is a behavior change, some other stuff wrapped around in the middle, and a payment change. The proposition is based on if you accept more risk, we can allow you to do things in a different way that bring value to us all. CMS largely right now, CMMI and others, they need information. They need data. They want to figure out what works and what doesn't. One of the areas under the macro statute right now that was designed to deliver data to CMS, CMMI, and CBO was PTAC. Now, it was envisioned much different than it ended up, and it ended up where it was because staffers had visionary ideas of what second pathways could look like, and then we ran into the realities of CBO scoring, and rightfully so, I think, pointed out some of the flaws in what we had considered. But the point is, there could be a second reporting option. There are flexibilities to implement it that would allow physician organizations to put forward prototypes of what an outcome measure could look like, of what an episode could look like, or what an APM could be. Identify ways to report on those prototypes that facilitates the data gathering for CMS and CMMI to help them better understand whether there's a value proposition that is worth exploring for purposes of payment. If you use the physician fee schedule to do it and reporting, you get to do something interesting. You don't have to apply payment consequences to it, which means largely every physician in this country could be reporting on a prototype. The information that they're reporting would help inform CMMI, as an example, about what projects it should select, with the goal of being more accurate in terms of the projects that it does select. In areas where the proposition fails, we've also largely succeeded because CMS and CMMI now know what doesn't work, but they may be able to extrapolate from the failed what might work in the future and then put it forward again. And lastly, you have increased provider confidence in the MACRA statute and found ways that they can better align their incentives with CMS's around identifying what the future of value looks like. The reason for the bad analogy on my dad's car was largely because MACRA is my dad's first year model car. It didn't work. I mean, it was a self-edit. It was not a great car. But the thing is, that car was in my family for 12 years after it got back from the shop, and it really didn't have problems. The funny thing is, and I won't again mention the auto maker, but model year 2 and 3 and 4 didn't have the problems that model year 1 did. To Sarah's point, the flexibility and bipartisanship in MACRA is a huge opportunity, basically. And it's a huge opportunity to utilize the entire Medicare program as a driver of value versus self-containing, let's say, all of the potential and just an area like CMMI. Going forward, my hope is that we can all engage in a conversation over how to improve the law in ways that make it a more effective driver of value. I'll stop there. Thank you very much, and happy to answer questions.
Yeah, thank you, Robert. I came into this panel with a couple of questions, and I think they've been answered pretty well by the panelists, so let me not have them repeat it. First, I want to ask the panelists if they have anything they'd like to say, inspired by what other panelists said, and then I'm going to go to the audience which did not have a chance to ask questions after the first panel, and I want to make sure you do after this one. Any comments? Okay. Yeah, there's a woman there with her hand up. Please introduce yourself.
Good morning. Can you hear me?
Yes.
My name is Jennifer McLaughlin with the Medical Group Management Association, which represents practice administrators. And to build on comments made by Sarah, Robert, and Sherry in the last panel, we've done a lot of work with the physician community, cardiology, AMA, to coalesce around this idea of multi-category credit. And I would especially be interested in your thoughts, Sarah, Jim, Robert as well. Some of the pushback we've gotten from officials in the administration has been that this would be the equivalent of double dipping. Because the statute lays out 4 separate categories, you have to separately report within each of them. But if, for instance, CMS did want to incentivize reporting around really important issues like take the opioid epidemic, and there were quality measures, there were improvement activities, potentially some cost lever, that's less likely right now, but absolutely a cert component. And they wanted to bundle that and allow group practices to report once on the activity that they're doing, say to consult prescription management drug program within their state, report that information to the public health registry, and document that through quality metrics, through improvement activities, through use of CERT. Our request to CMS was recognize that as a comprehensive sort of bundle, if you will, within MIPS, and don't require group practices to put in all of the burdensome requirements to separately meet those 3 different buckets, but rather just allow them to say, we're doing this important work, can we get credit across the MIPS program? The pushback again has been that could be perceived as double dipping. What are your thoughts on that?
So I'll answer this somewhat amorphously, but understanding I haven't seen all the details, let's say, of the proposal. Look, I do think, again, just to go back to Sherry's point, I don't want to put too many words in her mouth, so, but there is a lot of flexibility in the law to think about those 4 categories not as separate categories, but as areas, let's say, of measurement and activity that in some respects could be relied upon for the purposes of measurement. And again, the reweighting flexibilities that are in the law, if you look closely at the language around the reweighting, do allow for areas of condensing those 4 categories into smaller amounts of categories. It's largely wrapped around CPIA, but you know, the interpretive powers of the administration, basically, and the intent of Congress was always, we don't necessarily want to formulaically think about these 4 categories as simply 4 categories. Now, I will say this, I think the administration and others are still feeling their way around what is a very complex but very dynamic law. And so I think from an organizational standpoint, opportunities to engage the administration and Congress in what the opportunity is, but also maybe how to support it, can be an effective strategy for exploring new ways.
Other questions? Yes. And then there's the next one is this gentleman back there afterwards.
I would just add that, you know, I think the idea of MACRA in general was to streamline and to really, and to think about different ways to make reporting easier while also making it more useful and value-based. And so, I don't know the specifics of your proposal or your CMS's challenges, but even having different activities that you're doing within those 4 buckets, they could be all, even if you're doing them within the 4 buckets, they could be aligned towards the same goal, which is really what the intention is to, you know, drive value, whether it's in the opioid sphere and reducing those unnecessary prescriptions or others.
Yeah, let's hear from Aaron Liss.
Yeah, so I think Matthew brought up a very critical issue that I think has been understated throughout the morning, which is the importance of benchmark setting and target price setting and getting that right and having that be having those target prices and benchmarks be equitable. There was one element of it that I didn't hear that I think is a very significant concern. I was wondering how the panel would propose addressing this, but that is the degree of innovation in therapies and in diagnostics that we've seen over the past several years is fundamentally different than a lot of the data on which these models were based. And I think that I'd be interested in hearing your all's perspectives on how to account for that. To me, it just seems like that is it requires a degree of technical expertise in various specialties addressed by these APMs. That's hard to that's hard to get and hard to account for in the design of these models.
So share a couple thoughts, but I think to some extent this is just a hard technical problem that we don't have perfect answers to. But I think there are 2 broad approaches you can try to take. One is in terms of growth rates over time, is doing sort of more pure benchmarking of growth rates. So insofar as everyone's being affected by the same technological changes, that at least to some degree can capture those sorts of trends. Now, I think the challenge is you've got to really make sure that the peer groups you have for any given practice do have the same patient mix and are being affected by those technological changes in the right and in the same way. So I think that's a challenge. I think the other approach, and I think this becomes a bigger problem on some level narrower the models you're talking about are, right? If you've got a broader patient population, hopefully some of this averages out a little bit more, where there may be more technological change in this area of care, but not as much in that one. It's one of the reasons that over the long run, I tend to think that it's one of the advantages of total cost of care models over sort of episode-focused models, because I think they may be more robust to some of these challenges. But I think there's no perfect solution.
Okay, there's a gentleman back there.
Hi, David McNitt with National Health Advisors. I appreciate Robert and Sarah's points about where we were with SGR and where we've gone with MACRA, and the physician groups that I work with are very appreciative of the change and what Congress did to pull us out of that morass of constant SGR fixes. And I think that even though we appreciate what MIPS is trying to do, we do sort of look at it as, value purgatory, that we're sort of there as we wait for the advanced alternative payment models to come online. And we realize that's going to be a process. But by and large, the physicians I talk with, they don't just want one APM. They want multiple APMs. They want multiple on-ramps. And my question for those on-ramps sort of comes back to Dr. Fiedler. You made some comments about the mandatory nature of APMs. And I'm kind of wondering where should those lines be drawn? Should it be that you're on the MIPS track and then there's one on-ramp to APMs and you make that one APM mandatory for that group? Or do you wait for multiple options to be ready and say, okay, this clinical space has enough options for most of you to be in the APM track? And I think we're seeing it sort of play out with CJR being the first mandatory bundle, but also with BPCI Advanced coming online. For those physicians that are in CJR MSA, but are actually being successful under the BPCI model, that they do not have the option to continue on into the BPCIA model. They're actually being forced from a successful BPCI experience into CJR. And that's sort of another wrinkle to that mandatory aspect. And how do you see that playing out?
So I think there are two broad philosophies here in terms of whether we want broad choice of APMs or whether we want to really focus around a small set of models. I tend to be on the focus around a small set of models camp, and there are three reasons for that. One is I worry about a proliferation of a lot of different models just being a very complex environment, both for providers to navigate and for policymakers to manage. I think the second is, I think in many of those cases, I worry about balkanization, where we've got very narrow focused models that, because different types of clinicians and different types of providers are very focused on the measures and financial performance in their particular models, that we're inhibiting what in many cases is cross-provider type collaboration that we think we really want to foster. And then the third challenge is a major just arbitrage concern. That I think if we've got providers with a menu of 3 or 4 different models to choose from, inevitably the financial terms of some of those models are going to be idiosyncratically more attractive to them than the others. They're going to choose those, and I think that may be very good for the providers involved, but I think it could be very costly for the Medicare program. And so I think that tends to lead me towards a place of what we want is a fairly restricted menu of models that we can then find ways for a broad array of clinicians to find ways to engage with and enter into.
I'd like to maybe speak to that as well. I have a slightly different take. It's not to disagree at all, but look, I tend to think that more options are better. How you get to more options, I think, is a very important question, and there should be integrity in that. I would suggest right now that APMs largely, ACO specifically, the cost savings potential is largely undetermined at this point. I think the data supports that. I think we all see the potential and agree with the proposition that a new value proposition can save money. I think one of the downsides of focusing on a small subset are that you limit your chances for success and actually defining what that savings is. I think in part two, what I'd love to see is maybe an initial focus on some areas where a small set are there, but where the strategy is to identify components of those models that can be replicated for the purposes of allowing a little bit more individualization down at the provider level, both from a standpoint of specialty focus, but also geographic location and ability. Subspecialty right now, they may never get to an APM the way we're going right now. So in some respects, you're almost creating a second class of citizen among the physician community. where the system is focused on value and they have no ability on their own to drive it. Number two, I would suggest is that if we focus on small subsets and we continue on that and we utilize CMMI as the only approach, we run the risk of by the time we identify a model 7 to 10 years down the line, it's already outdated. Component approach in some respects allows us to look a little bit farther in the future. And again, I think there are ways in which physician reporting can help on an iterative basis inform what next generation models look like 10 and 15 years down in the future. Largely, I'll end with this, I think. I agree with you that MIPS today can be improved upon. I really do. I would also suggest that providers that are waiting under the current system for their place on the APM pathway could be waiting for 20 or more years. And I don't necessarily know if that's a sustainable place either.
Yeah, actually, as a final thought on this particular discussion, seems as though the big choice in APMs is whether to emphasize population models, and not only emphasize, versus episodic models, which I agree with Robert. They can have to be customized to lots of different specialties, but to me, that's the weakness of that approach. And the population approach could include, and I would hope would include, the flexibility for those, say, like ACOs, taking the population risk to actually innovate in the payment for particular episodes that are important to them and figure out how to do it their way rather than doing it through the regulatory channels, which take so much longer. I was going to close the meeting, but you seem eager enough to say something. So.
Hi, I'm a fourth-year resident physician at Georgetown, and I did my MBA on value-based care. I work very close with my medical society, which is the AAP-MNR Medical Society. And one of the big issues that I think we really should expand upon are building registries and making that more points on the scorecard. Because I think if we have registries that are meaningful and have like more measures within the registry that can capture data for evidence we can build episodes of care. And I think once we have that, we can really build APMs. What are your thoughts about expanding upon registries for each specialty society?
Well, I would say that there are registry pathways built into the law as a recognition of the usefulness of the data that is inputted into the registries, and also that the societies have developed and created as specific to the type of work that specific medical profession engages in. And so I think that Congress found the value in them and included them as a result of that. So there are obviously implementation questions that are being considered and changes that are even being considered in last week's new regulation that CMS put forth. But the use of the information that is put in there and it can provide some information that some answers to some questions that I think that are useful that you discussed.
And actually, if I can just maybe add to that a little bit too, it's funny that registries, and Sarah knows this, it's probably the most often used word in the MACRA statute. I mean, it's everywhere. It became a joke among the committees at one point because everything was "and registries." But there was a reason for that too, and it's somewhat more of maybe a hope for ways that registries could be utilized. And so I think, sir, to your question, the question becomes how they're recognized, not so much just the recognition themselves. But ultimately, CMS has a computer and capability problem in that CMS doesn't have the modern analytic capabilities that private businesses and organizations do. Somebody once told me that it has a 1980s computer system that's basically still an Apple IIe. It's not to denigrate CMS at all. It's not, but its ability to evaluate the value is limited. Registries empowered with modern analytics could be one potential, let's say, to improve CMS's ability to opine on whether a value proposition works or not. And recognizing registries as a conduit for gathering and submitting data to CMS might create shared opportunities for both the physician community and CMS to not only have the data, but also understand what the data is telling us. And again, I think it comes down to how the recognition happens, but if done in the right way, it could be pretty powerful. I agree with you.
One thing I would add here is just there's a strong, registries have a strong public good aspect in that there's going to, they enable a lot of types of research and learning that has systemic benefits that are potentially, beyond the level of the individual clinician. And so I do think, even if you were in a world where, where I got my wish and MIPS went away, I think maintaining some incentive for registry reporting would have a strong rationale for it.
And if I could just weigh in very quickly on this point as well, speaking for the commission staff, not the commission as a whole just yet, we are contemplating the role of registries in overall, physician value improvement activities. And some of the things we would be concerned about if these become a vehicle for again, moving substantial amounts of Medicare dollars around would be, what kind of data validation efforts occur on the front end? How open are these things? How accessible is the data to, the research community, to policymakers? What activities do the owners or managers of the registries do to push that information out in some aggregated form to the people who submitted it in order to ensure that it is indeed being used for purposes of quality improvement, practice improvement, as opposed to just sitting in the registry as a black box, allowing a submitter to say, yes, I participated in a registry. So we think there is probably some potential there, but we would want to see how that information is actually used to drive change before we would buy into this as, again, a vehicle for moving Medicare dollars around.
Thank you. One final thing on registries. I'm a public trustee of the American Academy of Ophthalmology, and it's been exciting as that academy has developed a very successful registry, and it is going to really advance knowledge about what works and what doesn't work in ophthalmology, besides all the other things about giving feedback to physicians as to how they're doing. I'd like to thank this panel. They've done a marvelous job, as well as the earlier panel. I want to thank Lauren Adler and Abby Durak of the Center for Health Policy staff for planning this conference and supporting it. And finally, to the Schaeffer Initiative, USC-Brookings Schaeffer Initiative for Health Policy, for providing the funds to pursue it. Thank you all very much.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.